I'd now like to welcome Professor Sancha Aranda, Director of Cancer Services and Information, Deputy CEO of the Cancer Institute. Sancha and her team are focused on improving health systems delivery in cancer. We've got a fantastic army of people dedicated, clinicians dedicated to treating cancer across the state. The real gains in cancer control for people diagnosed with cancer are going to come from better systems level integration. And if we can do that between primary, secondary and tertiary care, within tertiary care, and with our community more broadly, we will make a huge impact on cancer. The International Agency for Research in Cancer suggests that were we to apply the evidence that we have today, no new technology, no new drugs, no new procedures, we would improve cancer outcomes by between 10 and 15%. That's the challenge for us today, and Sancha, we've got a couple of really great presentations this morning to take that forward. The floor is yours. Thank you.
Thank you, David. And David also has to whip off and be with the Minister at the next at the event at the SAN, opening their new cancer centre this morning, which is an exciting development for the state, but he promises he'll come back. I'd like to start also by acknowledging the traditional owners on the land of which we meet today and to pay my respects to their elders, past and present. I'd also like to give some thanks to start with to some of the teams behind some of the work this morning. I'd particularly like to thank the New South Wales Oncology Lung Cancer Group and the Cancer Analysis team, and in particular our relatively new knowledge broker Tina Chen for her work on the lung cancer report. She's taken what is affectionately known in our organisation as the mothership, which is a report about that thick about lung cancer, and turned it into something incredibly accessible to the public, and for that I thank her and also our communications team who've worked with her closely on producing that. I'd also like to thank Sue Schweck, who this is almost her finale event. Sue is going back to work as a occupational therapist, but has been instrumental in putting today's event on, along with Megan Varlow, Graham Stevenson and Tia Mock. So the behind the scenes team, thank you all very much as well. So as David said, the systems change is actually the fundamental way in which we will change cancer outcomes in New South Wales and around the world. And shifting those outcomes is actually in your hands, which is why it is a great pleasure for me today to introduce our keynote speakers who are going to be speaking about building capacity for culture and change and setting the scenes for how our health system needs to really reinvent itself as a change industry. So I'm not sure how often we get the opportunity to do international couple recruitment, but we've done it this time. We've imported from Scotland the wonderful Gerry and Carrie Marr. Gerry is currently the Chief Executive at South Eastern Sydney Local Health District, and he commenced this role in February 2014. After retiring from his role in Scotland to follow Carrie to Australia, or to come with Carrie to Australia. Importantly, Gerry's had 13 years in its senior executive roles, beginning life as a nurse, which is go girls and boys in nursing. Gerry has led the implementation of a range of quality programs within the Scottish health system and was a non-executive board member of Healthcare Improvement Scotland. He's an in-demand international guest speaker on the topic of quality and safety in healthcare. But in his role as Chief Executive of NHS Tayside between 2010 and 2013, Gerry was responsible for the provision of community through to tertiary level services, including cancer services, for a population of 400,000 people. And he importantly took Tayside to become one of the top performing NHS boards in Scotland and has had a range of roles in pan-Scotland activities, including diabetes improvement. Carrie Marr is the Executive Director of Organisational Effectiveness at the Western Sydney Local Health District, also has a background in nursing. She has a long-term in oncology nursing, indeed, a long-term interest and hands-on involvement in patient safety and the science of improvement. Her previous healthcare system role at Tayside was the first site in Scotland and one of only 4 in the UK to be a pilot site for the Healthcare Foundation's Safer Patients initiative. The significant successes of the project encouraged Carrie to drive forward a pioneering approach to building capacity and capacity for clinical quality and patient safety. And as a result, her work helped Tayside to become a centre of excellence for improvement methodologies, which culminated with the launch in February 2011 of the Tayside Centre for Organisational Effectiveness, and it's these skills that she brings to New South Wales. This centre acts as an innovations hub in line with our theme of our conference, supporting and enabling innovation and quality improvement both nationally and internationally. And Carrie continues that in her role at Western Sydney Local Health District, and we look forward to seeing the influence of both Carrie and Gerry's approaches across our health system as they embed themselves in their roles. And it's my pleasure to welcome them here to talk to us this morning.
Good morning, everyone. It's an absolute privilege to be invited to speak here this morning amongst this audience. I won't be speaking about cancer, of course. That's your job and your expertise. What we would like to do this morning is, in the first half of this presentation, I would like to talk about what the leaders of healthcare systems should be thinking about as we move into 21st century healthcare. And then Carrie will take us through some of the ways that we can perhaps think about innovation in our systems. So, a little bit about quality and cost, but more importantly, much more about value and not cost. Talking about an international movement about the triple aim for populations that has been embraced across many, many countries, and I know that there are good evidence of that in Australia as well. And beginning to talk about person and community-centred care. Carrie will lead on that, and improvement for change and capability, and wrapped around that, of course, is the issue of leadership. So what should leaders in healthcare be thinking about in the 21st century? Well, of course, we can never get away from the financial challenges that we face. As you know, in Europe had a meltdown that resulted in a loss of 7% growth for the last 5 years in healthcare. At a time when the demographics across the world raised the great challenge of how we're going to care, particularly for our older populations. In Tayside, we extrapolated that if we did nothing, we just continued in the way that we delivered care, by 2031 we would have to have built a hospital of another 500 beds, which of course is preposterous. Can't afford it, we don't need it, and we have no one to staff it, because the demographics of our workforce are moving in exactly the opposite direction. But the continual and welcome emphasis now on safety and quality. And of course, most leaders go on about there's not sufficient money. Well, I've got an interesting proposition for you. I think there's more than enough money in healthcare. And the simple fact of the matter is there isn't going to be any more money. And so we have to reorganise ourselves, and we have to think about the whole issue of waste, harm and variation. And in Tayside, that was our single theme. How can we take waste out of our system? How can we reduce the harm that we regrettably happens in our hospitals, in our community settings, unintentionally of course, but more importantly, how can we take away the unwarranted variation in the way that we deliver services and the outcomes for patients? That, to me, is the focus for innovation. And I describe that as a choice. How many of you are in organisations that are completely obsessed with the 5% savings? That every conversation is about money, every conversation is about how we meet our budgetary requirements. Well, what I say to people who create that kind of leadership is, you'll probably survive. Probably not for long, but you'll survive for some period of time. You'll demoralise your organisation in the process, and you'll be on the wrong page with the wrong focus. Think about thriving. Think about the 95%. My district is 1.5 billion. We're adrift by about 20 million. Why am I spending 95% of my time talking about a 5% problem? Let's really reorganise ourselves to think differently about the huge amount of resources we have available to us, and to think that we can take that and eradicate that waste and harm and variation in our system. And what we have introduced in the district is the work that we did in Tayside around the triple aim, that we must be much more focused on population health, we must be much more focused on the experience of care that our patients have, and we have to think in terms of value and per capita costs, not in the dollar sign. That's the most important thing. It's all very well to concentrate on care in the hospitals, and that's been very much the responsibility of the districts. But until we begin to embrace our population health, until we begin to think at a systems level, then we won't do what David has challenged us today, to actually improve the care of our patients and their outcomes by taking a systems-wide approach to the care that we deliver. So I would suggest that there are 4 pillars of change. We call them actually 4 pillars of reform in my own country in Scotland. A decisive shift towards prevention, a real effort on actually saying that prevention is the thing that we should concentrate on. Greater integration of public services at a local level with partnership, collaboration and effective leadership. Now I hear all the time in the countries that I speak about how the financial system is toxic, how the incentives aren't aligned. Well, yes, but that's no different in Australia than it is in Scotland, than it is in the US. We just have to recognise that there is no perfect financial system underpinning a healthcare system. And we actually have to understand that the thing that drives innovation is relationships. It's the collaboration and the partnership and the effective leadership that we create in systems that make that happen. And of course, the Ministry is now committed to integrated care, and I think that's the opportunity for driving things differently. I think we need far greater investment in people who deliver the services through enhanced workforce development and effective leadership, and Carrie will touch on that particular topic as she goes through her talk. And a sharper focus on improving performance through greater transparency, innovation, and the use of digital technology, which the health service has been particularly slow to embrace over the last 10 to 15 years. But if we were maybe doing a bit of a self-assessment, I talk about the 3 curves, getting to the 3rd curve. So if you look at that slide for a moment and say, if this was me sitting in a meeting room in my own district or clinic or community, where are we on the curve? I think far too many healthcare organisations are in performance curve. The endless KPIs, red, amber, green, the enemy of improvement. 1 dot, green good, red bad, and bang the table and the green will stay and the red will turn remarkably to green. An absolute obsession amongst governments and amongst institutions to think about performance. When do you know whether you're in a performance conversation, a judgment, or in an improvement conversation? Where are the improvement conversations in your organisation where people are able to sit down and say, in the 2nd curve, how are we going to improve what we do? And how are we going to be given the time and the space? And how are we going to be allowed to get it wrong sometimes so that we can actually learn from it and improve as we go along? And so I think as a health service globally, we are too stuck in performance. We're maybe creeping up the improvement curve. But the real systems thinking says that what we have to do is get to co-producing with our communities their healthcare. And that we actually see communities as an asset, and we see the patient as an asset. The greatest asset in any illness is the patient and the family who are having to deal with that. They are the asset, and we should recognise that their contribution to their illness and how we manage it is the most important thing. And so we are thinking about, in our district, how do we get to that 3rd curve? And I think what Carrie wants to talk about is that you do that through thinking and reordering your thoughts around improvement and innovation. So a number of years ago, we came across Anthony Staines. Anthony Staines was a researcher in WHO. And what Anthony did was he did a PhD and he observed 3 organisations internationally. Most of you probably heard of Intermountain in Salt Lake City, world famous for its drive for improvement. The other was Jönköping in Sweden, which I've got a very close association with over the last 10 years, and the other was Van der Graaf in Holland. What he observed became the basis of our plans in Tayside for designing our organisational effectiveness strategy. And what he observed were the following things: building infrastructure and capacity in these organisations that were excelling, really understood what to do. On the right-hand side, they had technology and information and measurement that was real-time and meaningful to clinicians, not measurement for judgment that would satisfy ministries and departments of health. And that measurement was always owned by frontline clinicians, and it meant something to them. It gave them information that said, this information tells me how I can improve. Not, this is the information that I'll send upstairs and wonder where the hell it goes and never see it again. So a real evidence of people working at frontline level with information. They also saw great will and commitment towards the language of improvement. It was in the DNA of these organisations, with a clear vision and strategy and a complete commitment to a culture that supported and improved frontline staffs. And one of the things that Anthony observed was that these organisations were ruthlessly focused on their microsystems. They were not in the boardroom. They were in the front line and the microsystem, building capacity and capability for the staff. And of course, they had very comprehensive learning organisation with quality improvement that was evidence-based, supported by leadership development. But more than anything, these organisations had shown great resilience in maintaining priorities during crisis, because every health system has their crisis. Europe thought it was coming out of it, and it's probably slipping back into it. In England this week, we had people on strike for the first time in 30 years. It's not out of the woods by any means. But why does Salford Royal Hospital still deliver the excellence it does in the same economic and the same crisis environment that other hospitals who are failing badly? The answer, Anthony Stein suggests, is in the characteristics that you see on this slide. And the other thing they noticed, and I keep telling my chairman this, the stability of general management. Most of these organisations' chief execs have been there for 13 years or more. In England, the shelf life of a chief executive is less than a premiership manager in the football. 1.5, 2 years, and they're out the door. And of course, the clinicians say, I'll wait for the next bus, thank you. I'm not listening to you. Someone else is coming along in 2 years. But these organisations had tremendous stability. They made it their business to be stable in the way that they ran their organisations. My ambition as a CE is to challenge my colleagues, to challenge the chairs and challenge the ministry about reordering their thinking about saying that we have to think at a systems level across the whole of our community, and we have to do it on the basis that the community and the people who are living in that community are the assets that we should treasure and work with to deliver effective healthcare for our populations. And so taking Anthony's work and maybe pass over to Carrie to say, so how does that begin to translate into some strategies and ideas about how you can innovate in your healthcare system? Thank you.
Good morning, everybody. I'm just going to carry straight on from what Gerry's talked about. So when we talked about the work of Anthony, what we talked about in Scotland was a proposition, and a proposition for our healthcare organisation, our system. And the proposition was that if the best systems internationally establish these kind of characteristics in the way they work, then why can't we? Yeah? And so that's our proposition as well for ourselves here in Sydney. Why could we not grow and nurture and sustain the same characteristics ourselves? We do know there's certain limitations and challenges to what we want to do, because in the organisations that do this really, really well, they've taken 2 to 5 years to create those conditions. Yeah? Intermountain, Culturum, Kaiser have all worked on this for many, many years. But the proposition that we'd like you to think about today is, what are the things that you could start to do in your systems to start to create those conditions over time? And when we looked in 2009 at the best systems, we saw no difference to what we're seeing today. So if you look at places like Kaiser are describing the 6 leverage points the same way as Anthony was back in 2009. So, we know what we need to do. We know the conditions we need to create in order to thrive. What we need to do is work out how we want to start doing this. Yeah? So, I'm going to talk a bit about some of those conditions and think a bit about how we could locally develop them in the systems that we have. And the first place that most of them started was on skills. What we do know is that unless you have a community of practitioners in your healthcare system who understand improvement science and can apply improvement methodology, you won't make the change that you want to make happen. And so what we know from those organisations that do this well is they have a planned approach. They actually know they need a certain number of experts and improvement leaders in their systems. And over time, they seek to build that. So in Kaiser, their plan is 0.5% of their staff as experts, full-time experts in improvement science, full-time people supporting frontline teams to look at improvement, to drive improvement and safety, to help people understand how to measure it, how to know if you're improving. They also train every single one of their executives and their board members in measurement, in data, in understanding improvement and quality. So they too can start to support the staff and patients and carers to get involved and to do it well. And the 10 to 15% is frontline clinicians. So how many clinicians do you need to start thinking about training to lead improvement, to drive improvement projects? 15% of Kaiser's staff are trained, usually on a week's programme, to lead improvement work and to know how to set up measurements. And the rest is everyone. So on your orientation in your organisation, how much do you talk about quality and safety? How much do you talk about improvement? If you work at South Central in Alaska, in your very first week of employment, no matter what your job, you are taught about improvement and safety and how important it is to the community of Alaska, not just the hospital where you're coming to work. So we've got a big challenge to try and think about how we help everybody understand it. And part of generating that skill base is to have enough people in our systems who can ask these questions, okay? And there's 4 questions that we have in our heads that if we know and we're asking these relentlessly, we know we're talking about improvement and quality, okay? Do we know how good we are today in the teams we're working in the service that we're delivering? Do we know how good we are today? Right? Not yesterday, today. Do we know, as Gerry said, where our waste, our unwarranted variation is in how we work? What data do we have? What evidence? What patient stories do we use to help us know that? How do we benchmark ourselves? Do we know what the best in class is? Not just on our doorstep, but internationally. We used to have a great saying in Scotland that if you only compare yourself with the people around you, you just become the cream of the crap. That's a real Scottish saying. So the stretch is to have an ambition to be benchmarked against the best internationally, not just the people around you. And fourthly, how are you organised to respond to what you know? Yeah? Do you know your rate of improvement? Do you have the capability? So some questions for you to take back and think about after today. And a lot of what Gerry's talked about has been about thinking differently, rewiring our brains, yeah? Having new mental models around how we want to improve healthcare and not thinking about it in the traditional ways we have. And those mental models are really, for us, about shifting from volume to value. The value in being person-centred, not condition-centred. The value in thinking about assets, not problems. the value in thinking about how we can improve what we do every day with not just ourselves, but with the people we care for, their families and our communities. So a couple of thoughts there about how we can bring more value rather than volume into our conversation. And I'm going to start with, it is a patient story. This is a conversation with a brilliant guy called Trevor. He's going to talk to you about diabetes, but more importantly, he's going to talk to you about what it means to him. Okay, could we start the video, please?
Hi, I'm Trevor Torres. I have eczema, asthma, I suffer from sleep deprivation, I'm allergic to nuts, but the fun one is juvenile diabetes, or type 1 diabetes. I was diagnosed with diabetes probably like 2 years ago, and I used to describe myself as a professional diabetic, except the problem with that is I haven't figured out a way to get paid yet. So until I do that, I like to call myself a diabetes evangelist, because I would recommend type 1 diabetes to anyone, and I'll get to that in a second. Just to describe a little bit with my situation, I pretty much do everything on my own. I track my own blood sugar, give myself my own shots, calculate my meals and insulin, and I've pretty much memorized the carbohydrate content of like every food in my house just because of how much I use it. So it's kind of a fun party trick, like, oh, hey Trevor, how many carbs are in like this soda? And I'm like, it's 42 for 1 can. And I would definitely recommend diabetes to everyone for 2 reasons, mainly, although there's a lot. I'm not going to list them all. One, it's so much easier to be healthier if you are a type 1 diabetic, because you're already looking at all the nutrition facts on your foods anyway. So I think that a lot of the diet problems people have is just because they kind of unconsciously eat something bad. They're like, oh, you know, they look at their day or whatever and they're like, oops, I probably shouldn't have eaten like that many cupcakes or something. And another thing I really like about diabetes, I feel like it makes me more confident. It's like, and this might be a little irrational, but it's like any accomplishment I have, I feel like it's that much cooler because I have diabetes. So I accomplished this thing and I had diabetes at the same time. There's 2 main things. One, don't condescend. Especially for me, I don't really like that because I am one of the smarter patients, and so I guess I could have said stay out of my way, but that doesn't really help very much. When I was first diagnosed with diabetes, they were like, you can give yourself insulin in one of 2 ways. You can do it based on your blood sugar. If you have higher blood sugar, give yourself more insulin and so forth. Or you can do it based on what you're going to eat. You know, if you're going to eat X amount, give yourself X amount of insulin. And I was just like, well, that doesn't make sense. Why don't I just come up with an algorithm that incorporates both variables? So again, that's probably a little atypical, but if they already have something figured out, you don't necessarily need to lower the level of your explanation down to what you perceive your patient's level to be. You can explain something, and then if your patient doesn't understand it, they can ask, you know, for clarification. Now that may be just me, but I really hate it when I feel like I'm being talked down to, and that also might be my age. I know we kids are a little upstart about that. So it's like, another thing that I hate is never say poke. I'm going to poke you. Like, no, you're not going to poke me. You're going to stab me, okay? A poke is where you prod someone with your finger. A stab is where you insert a sharp metal object with the intent either to inject a foreign substance into the body or to draw blood by breaking the skin. Little rant there. Another thing that's important is to understand how your patient learns. And I don't have all the answers here, but I know that for me, I really like to know why something's being done. Like, if a doctor just says, you know, you need to eat this way, you need to do this thing, take this treatment, anything. If they tell me to do something, they better tell me why I have to do it. Because, one, that way I know I actually should do it. Because people tell you to do things all the time. And if I did everything that I know I should do, I would not have, I don't have time to do that. Ain't nobody got time for that. But if my doctor says, you need to take this medication because this is what it's going to do scientifically in your body, this is what's going to happen if you don't do it, this is what's going to happen if you do, then I know exactly why I should, and then I'll be much more likely to do it. If somebody is like, if a doctor is complaining like, oh, my patient didn't do X, Y, and Z, and then you didn't tell them why, you just told them to do it, well, of course they didn't do it.
So Trevor actually talks to us about something that's quite important, that for him, he wants advice, he wants connection with his care team, he wants to ask questions. He actually doesn't want to come to hospital to do it. If he could get his doctor to text him, he'd love it, but he's kind of compromised by phone calls. But he wants people to recognise that he's got a bigger part of his life out with the healthcare system. And he wants to take control of how that happens. So just some of the things that is worth thinking about in terms of how we design some of our pathways. And if you think about all the determinants of health, all of those social and economic factors that Kevin was bringing to bear, health is only one dot on that chart of things that actually influence how we feel around our health and well-being. And how do we as practitioners and carers think more widely about what matters to people? Yeah? And there's been some really interesting thinking about different approaches to getting people into this conversation. So I don't know if you've heard about the 5,000 hours a year or the 23.5 hours a day, but the 5,000 hours a year is the conversation about those of us who have long-term conditions. That over the course of a year, we might only be in hospital or seeing our specialists 6, maybe 8 hours of that year. But actually, our waking hours outside those services are when we have to manage our health. We have to make sure that we get the most out of the quality of our lives. And so there's a conversation emerging internationally about what about if we focused on how to help people thrive in their 5,000 hours, not just thinking about how they're presenting in the 6 hours a year in the clinic. Yeah? And if you're on YouTube, there's a great YouTube by a guy called Dr. Mike called 23.5 hours. And he talks about the 23.5 hours you can have a day to do anything you want if you do one intervention that will give you better health, better outcomes, and longer life. And that's 30 minutes of walking a day. And rather than focus people on exercising, he talks about doing more with your 23.5 hours. So how can we flip? Okay, how can we flip how we think about this? There's a really good article in the BMJ this month by Maureen Buzzignano about flipping healthcare. And she talks about flipping the way we traditionally have thought and thinking more innovatively about how patients and carers and communities want to engage with us in conversations about care. So if you've got time, go and look at the YouTube. It's great to think about differently. And the other bit is the questions and the conversations, isn't it? We're doing a lot of work in New South Wales about person-centred care, and our person-centred care challenge in each of the districts. There is a real need for us to think much, much more disciplined about the question of what matters most to you, the patient, to you, the carer, not to us, the professional. And how can we do more of that? And part of that is also a conversation about understanding more about what are in patients' lives when they come to see you in hospital. And this is just an illustration of what sometimes we don't know. That question to patients about what's your story? Yeah? What more to your life do I not know that will make me understand you more as a person? Yeah? And if more clinicians had asked my dad that question, they may have seen that he wasn't just someone who'd been diagnosed with Alzheimer's, but he was someone who had a story to tell. If actually people took the time to talk about his story and not just his condition. The other opportunity around this is how can we bring this into health services. And this is an example of a nurse in York Hill Hospital in Glasgow. She came to an improvement conference. She heard about the importance of putting what matters most from her patients out front in the ward. And so she started in her ward. It was a children's hospital. And she got the children to draw what mattered most to them. And they stuck it on their doors or at the ends of their beds. And within 6 months, that nurse had got every single ward in York Hill Hospital to do that. So every patient, the first day they came in, drew what mattered to them. And wasn't that really powerful and engaging and much more about partnering with our patients and how we work with them? So the other piece of work I quickly just want you to think about is, if you haven't read it, there's a book out by Cotter called Accelerate. He's written a lot of work about engaging staff, helping to share vision, gain will and commitment in the people that you work with. But his new book's really interesting because he's put a bit of a challenge out to healthcare. He's suggested that historically and traditionally, we work through hierarchy. We work in structure. We need a lot of permission to do things. We usually have to go to 5 committees. We have to wait a long time to get permission. His proposition is that we should flip that. We should rely more on networks. We should rely more on the connection of people across the front line of our services to get together and effect change much more locally on the front line and not through the structures and hierarchy of our organisations. He talks about that change coming from emotional connection, not just rational connections, yeah? And how we can create, so improvement becomes a movement, becomes like an infection, becomes viral, becomes the conversation of networks. And so his challenge is, how much can we do to sustain and nurture networks in our healthcare systems? Because that would be fundamentally very, very different. But it means that for those of us that hold hierarchies and structures dear, we're going to have to let go of some control. We're going to have to let frontline staff and patients and carers get on with it, yeah? And give permission. That's what improvement culture is all about. And we've had a great example of the power of networks and what that can do in Scotland. We are 2 years into the Early Years Collaborative. For the first time ever in our country, we had over 300 people in a room from health, housing, education, social work, employment services, the police and the fire brigade. And they all pledged collectively to make life better for every child in Scotland, to improve their outcomes. Because how we treat children in the first years of their life affects their health later on. It can increase their risk of cardiac disease. It can increase their well-being. What we can do for early years could change our healthcare generationally. But the collective change, because of all these people coming together, has proved to be the most significant change we've ever made. So it's thinking out your box as well. How can you think past the walls of healthcare? How can we get the right people in the room to actually form the coalitions that we need for the change, no matter what kind of improvement we're looking for? And as Gerry said at the very beginning, coalitions not just of organisations, but coalitions that partner our communities, who actually want to be in the heart of that conversation, so we can use the assets of that community to build health. So we just thought we'd leave you with an invitation for the rest of the day. Given that we've said networks is the way we want to work, permission, we talk about ask for forgiveness, not permission, just do it. I shouldn't say that, my chief exec's in the audience. But our invitation for you today is that you all personally have got the opportunity to influence change in what you do every day. That you are all in your own way potentially disruptive innovators. That's our role. That's what we think we come to healthcare to do, to be disruptive innovators, to ask the questions, to think differently, to be curious about why we're doing things the way we always have. Yeah? So what could you be disruptively innovative about when you go back? Yeah? Either on your own or as a first follower, because you'll meet a lot of other people in your systems who want to be innovators. Their innovation will only happen if they can get a follower. Yeah? So, you know, be courageous and find that innovation in your system. And if you want a bit of inspiration to get you going, then the second YouTube clip for you to go home and watch is called The Lone Nutter. Yeah? And The Lone Nutter, that's what it's called on YouTube, The Lone Nutter is a brilliant example of how one person who may stand up to be courageous can only actually see it through once one other person starts to follow him. Yeah? So our invitation today is for you to go out and think about your responsibility to actually become part of a network in New South Wales for disruption and innovation. And because we have to do it. Okay? Thank you.
Stay there, stay there, stay there. We've got 5 minutes for questions. If anyone has a question for Gerry and Carrie. John. There are riding mics. Robin's coming behind you.
Thank you very much. My name is John Stubbs. I'm on the board of the Cancer Institute and I'm a 13-year cancer survivor. It's music to my ears hearing what you've said, because I've been in the health system now for 13 odd years and you just see duplication and you see the same. I'm assuming that the Scottish health system is similar to ours. So is there one driver that starts all this? Is it the one nutter that does it? And then how do you get the bureaucracy on board to follow what the clinicians and the patients are seeking?
Do you want to start first?
To be fair, one of the unique advantages in Scotland is the way the system's organised. So as a CEO, I was responsible for primary care and secondary care. It was a one funding stream, so I have to confess that is a big challenge for Australia and New South Wales. But all the evidence is that these organisations create their own DNA. It comes from those organisations themselves and very often influences. So in Scotland, we were the very first to do the Patient Safety International Programme, and that then became a national programme. Government took on board 2 years of work that we had actually done. But when you look around systems, you actually do see the lone nutter organisation saying, this is going to be in our DNA. And what I was saying to an audience the other week with David Dalton from Salford was that when David presents Salford's work, most of us in New South Wales could tick a box and say, yeah, we do that, but we don't have it in the DNA of our systems and our hospitals. We have them from programmes from the pillars, or we have them from the ministry, and they're designed as programmes, and we have to then send information back. All of these organisations have really built it into the DNA of what they do, and the executives in those organisations say their one job, and my one job is to create the conditions to allow that to happen. It's not difficult.
If I can add to that. So there's two things from an organisational development perspective I would see that has helped. Firstly, the whole conversation about dialogue and discussion. So for us, dialogue is a tool. Yeah? The more we can bring people together to talk about what we know, which is around what data we have and what we can do about it. We don't have any conversations in Scotland around a care pathway which does not include everybody across the system. It's now become so routine that everybody just expects it. So how can you facilitate the conversation that you need in your systems to be talking about the right thing? Because whatever the conversation is talking about will establish your culture. Yeah? So and for us, that's really how we brought our clinicians around the conversation.
Hi, I'm Tim Shaw. I loved your comment, Gerry, about the PhD that was actually useful. Since there was a few people in the audience who've got PhDs gathering dust on shelves that have been read by nobody other than themselves, but I might include myself in that. I mean, obviously, I think one of the key challenges we have at the moment on some levels, particularly given the Cancer Institute is a major funder of research, including the translational research centres, is actually making research that's relevant and engaging. I mean, I'm really grappling in my own work around how we engage quality improvement and implementation implementation science and actually get research to be relevant while still maintaining its integrity as a research discipline, but engaging more. And Carrie and I have been having some conversations about that recently. I just wondered if you've got any kind of examples of that from Scotland where that's actually been kind of working, because there is a natural tension between those domains.
Yeah, when we started this, it was very tough with our clinicians because the science that you're trained in, they thought all this quality improvement was a load of psychobabble, you know. I said, where's the randomised trial? I said, well, when did they do one with a parachute? Sometimes you don't need randomised trials to prove anything. And so we just very gradually had to work with our clinicians on the ground and say, let's develop a dialogue of mutual respect. Let's respect what you do in research, but give us time and space to demonstrate to you over measurement and over time that this can complement the work that you're doing. But internationally, I think there was a lot of literature come out of America in particular, saying we need to start to do some research on science improvement. And unfortunately, we left at the time, but just as we were leaving, we actually got a $3 million grant to do the first applied research in quality improvement and improvement science in Tayside. And I think we need to do that, and I think we need to start publishing, and I think we need to recognise that the debate has to be healthy and based on mutual respect.
Yeah. And Tim, the other example I would have is that locally in the system, we established an improvement collaborative. So this is our network. This was 7 clinical teams in the acute hospital improving care pathways for people who had Alzheimer's and dementia. So they ran an improvement programme for a year and a half. And out of that, we then got research monies to then pursue the research that followed on from the improvement. So they can be mutually inclusive of each other. I think the more people see you don't have to be in one camp or another. It's the same space. You can actually do both.
Thank you both very much,
Thank you.
Please thank me. Join me in thanking me. And I'm sure that we should also thank Danny O'Connor, the Chief Exec of Western Sydney, for recruiting Carrie and also bringing, therefore, Gerry to our shores.